Good evening, everybody. My name is Kamilah Martin Proctor. I am the founder of the Martin MS Alliance Foundation. It is such a pleasure to be here, and I want to thank each and every one of you for coming out to have this critical conversation around multiple sclerosis, patient support, and awareness. My organization specifically looks at multiple sclerosis in underrepresented communities, particularly those of Black and Brown descent. We take a look at the various issues regarding communities of color, particularly abating the stigma that multiple sclerosis does not affect communities of color. We do this through three main goals. We work with regards to addressing educational access. With regards to educational access, we have partnerships with VEC. We also have partnerships with our community colleges. I'm sorry, this microphone is reverberating so loudly. I hope everybody can hear me, but I'm not overpowering. Okay, excellent. Thank you so much. And we actually partner with the Kelsey as well, and that works with regards to making sure that housing is accessible. I don't know, did you know that the Bureau of Labor Statistics just recently put out stats that said individuals with disabilities are 50% more likely to be unemployed than the general population? 50%. That's not because they don't want to work. That's because there are structural and systemic barriers preventing individuals from working. And that includes all of us living with multiple sclerosis. So a lot of times my organization will go in to different companies and different venues to talk about advocacy for self and how to be an accessible and inclusive employer. With regards to the gap to higher education, we look at the barriers on just filling out the standard application form on a website that may not necessarily be accessible to screen readers. I don't know about anybody else, but after 2, 3, 4 bouts of optic neuritis, Zoom text is my best friend. And Dragon Speak on another day, depending on where I am in the situation, in the journey of living with multiple sclerosis, which I've had since I was 16 years old. And I look good, like 3, 4 years ago. It truly is a pleasure being here, and I wanted to mention a couple fun things that we do with the foundation. I know I only got a couple more minutes to kind of wrap this up, but I do hope that you guys look at our website. We have some information that's been passed around where we look specifically at the intersections of multiple sclerosis and pop culture. So I've got 3 questions, and if you win, you get a stress ball. It's good for your feet. It's good for all that stuff. So, question number 1. What was the name of the show and or character and or actor that starred as the first president with multiple sclerosis? Very good. You get a stress ball. The West Wing. Okay. Question number 2. What is the name of the iconic actor, African-American male actor and comedian that also lived with multiple sclerosis? He can be called one of the founding members of Saturday Night Live. I see a hand in the back. Yes, you get a stress ball. Last question, and this is for us locals. And here in the DMV, what is the name of the singer who is living with multiple sclerosis who is currently married to one of the all-time basketball greats? I see a hand in the back. Is it to the left? Yes. Very good. You get a stress ball. Thank you. That is some of the fun stuff that we do with our foundation on Sunday Fun Day, because I did initially start it as a young African-American female living with multiple sclerosis that really just was trying to find other people to talk to and learning how to live and balance this journey with MS. I hope we all enjoy this conversation. And before I close out, I want to say thank you to my friends and family, and I will leave you with the iconic words of that amazing, historic freedom fighter and military general who was also a disabled Black woman whose face should be on the $20 bill. We're working on it. Just keep going. Thank you so much for your time.
All right, so before I introduce our next speaker, I want to let everybody know online and in the audience that today we had our supporters, our sponsors of today's program, and I do need to tell you who they are. So we had EMD Serono and Genentech. We have Novartis and Sandoz and TG Therapeutics. And I want to thank them each for being here and for supporting our program. I want everybody to say thank you. Come on, let's hear a round of applause and say thank you. We also had many exhibitors at the program. We had Alexion and Biogen and EMD Serono, Genentech, Novartis, Sandoz, and TG Therapeutics. And I want to thank them all for being there too. We did have Kamilah Martin, who's a founder of an MS organization up in the area. And I wanted to thank her. She's with the Martin MS Alliance Foundation. And so we do want to thank her for being online. And we also have coming up to speak next is Dawn Morgan. Dawn Morgan is an author and a podcaster of what's called The Unquiet Mind. So she'll be coming up in a moment. And then also we have Dr. Heidi Crayton. Dr. Heidi Crayton will be speaking with you about new MS treatment options, including the biosimilars. She'll be doing some talk on living well with multiple sclerosis, including some nutrition, sleep, exercise, and back to maybe a little bit more on medications and a little bit on access to care, especially in people in the outward regions outside of the metropolitan areas. So we do hope that she'll be able to cover all of that. And then Dr. Crayton asked me if she could do a little bit of a roundtable with the first two speakers who both have multiple sclerosis as well. So we want to make sure that everything is being covered. Let's continue. Let's get started with Dawn. Okay, thank you.
Hi, family. Just to close out real quick, I understand that my friends on the interweb did not hear the answers to the questions. It was the West Wing, Richard Pryor, and Tamia Hill, all amazing MS advocates. Dawn?
Hello and good evening, everyone. My name is Dawn Morgan. Thank you, Stuart, so much for this opportunity, and thank you all for being here. It is such a pleasure to be able to speak in front of fellow MSers and people who are interested in finding out more about multiple sclerosis. Oh, I'm sorry. I will speak directly into the microphone. Okay. Thank you so much. I will give you a little history about myself before I talk about the things that I'm doing and the things that I have embarked on this long MS journey. So as I stated, my name is Dawn Morgan. I was diagnosed with MS 24 years ago. It will be 25 years in May. And I started out on my journey really confused and not understanding what MS was. I remember when my radiologist provided the report and gave it over to the healthcare provider that I was seeing at the time. I think it was my primary care. And she had said, well, it's MS. And me not knowing what MS was or an autoimmune illness was, I instantly thought of Parkinson's. I thought, you mean I'm going to look like Janet Reno? And at the time, for younger people, they probably don't remember Janet Reno, but the older people do remember. Thank you. But that was my only connection to something neurological, something that was going to alter the body and alter your mind. And so I didn't think doom and gloom. I just naturally assumed, okay, well, I'm young and I'll get over it. And I was absolutely blessed to have access to care. So to hear you speak about that, Kamilah, and I'm sure Dr. Crayton will touch on this as well, it is so critical to be able to find clinicians that will understand you and that will listen to you and that you have access to those individuals. I never had a stumbling block. I always was able to find the right doctors, and I went for a second opinion, and I got really lucky to have the best doctor on this planet, probably ever to live and walk the earth, which is Dr. Heidi Crayton. And that started my journey. So When I was 24 when I was diagnosed, 24 or 25. I never thought that this illness would lead me into patient advocacy and into standing up for what the disabled community needs, what the autoimmune community needs. I never found myself talking in front of people. I always feared that. I thought, no one's going to listen to me. Well, people do listen. I ended up doing a documentary on PBS. So if you all ever search for it, you'll see Blacks and African Americans and MS. It's on PBS somewhere. And I actually, Biogen actually sponsored that lovely documentary. So thank you, Biogen. And it also led me to podcasting. I was in denial for quite some time, probably over a decade. I never wanted to address MS. I knew that I had things going on or different challenges, but I never wanted to discuss it. And then probably, I would say 12 years into this journey, I decided that, I really want to make a difference. I want to be a patient advocate. I want to speak with newly diagnosed individuals, which is where I am now. And so I'm a health coach, and I prepare newly diagnosed patients for what's ahead. Because it is, although we have a similar path with MS, everyone's multiple sclerosis looks different. And I think that it's important to really pull back the layers on what's happening in your particular journey. And that's what led me to compose an ebook. And I started writing, and the ebook is titled The Relationship Between Patient and Healthcare Provider, Things That You Both Should Know. If I did not have the support of my doctor, my MS specialist, I probably would have crumbled many, many years ago. I mean, and I've had times where I've wanted to crawl under a rock for sure. But there's something to be said when you find that special someone that says, I'm proud of you. And it's not someone who isn't even your blood relative. Of course, mom and dad, they pat you on the back, they hug you, they kiss you, and I'm proud of you. It means a lot, of course. But to hear that from your clinician, someone who has seen your struggle, someone who knows you in and out, knows every part of your body and how you think and how you process, it really makes a difference. And so what I talk about with patients, with MS patients, is being able to communicate. There is a toolkit that you have to, I suppose, have in your back pocket when you have multiple sclerosis. Being able to communicate your needs, that's number one. If you don't go in and discuss what it is that you need or what you're looking for in care, it's almost doing yourself a disservice, because it's a two-way conversation in your doctor's visits. It's not just one-sided. It's not the doctor just explaining, well, this is the path of your MS and this is how we're going to treat it. No, I think it's a dual conversation. It's not just totally one-sided. And I think that making sure that you advocate for yourself as well is super important. Making sure that you understand what your needs are. You understand your illness, that you understand the verbiage. The vocabulary in MS will have your head spinning. What's an exacerbation? What's an MS specialist? I think I remember probably maybe about 5 years ago, I said, what's an MS specialist? I just know my neurologist. And I think Dr. Crayton said, well, I'm your MS specialist. So it's important to know the vocabulary and to speak up when you are not understanding, or if a particular therapy isn't working for you. And so that is my main focus now. And you can, of course, find me, in different podcasts and different episodes. I talk about anything from bladder issues to insomnia to anxiety, which is something that I deal with on a regular basis. And of course, just being your own advocate. And that's probably the main, I suppose, point that I would like to make. I really want people to understand what it means to speak up for yourself and what it means to focus on those positive health outcomes with your clinician. And assemble your team. I remember having an old MSer tell me once, make sure you have a team of doctors who are on the same page. And it's funny because last night I was listening to an old clip of the Dave Chappelle episode. And it was, I don't know if you all remember this, but it was where Rick James and Prince were playing basketball or his team or somebody, and they said, assemble your team. And I instantly thought, that is what you need to do when you have multiple sclerosis. Make sure you have a strong neurologist or MS specialist, someone that will advocate for you as well. Make sure you have a physical therapist. Make sure you have an ophthalmologist. I mean, it's just really important to ensure that you have all of the things that you need for the changes that you'll go through having MS. And so with that, I will say thank you. And again, I am really happy to be here, and I look forward to having more conversations. And I can turn this over to Dr. Crayton whenever she's ready. So thank you so much.
Thank you very much, Dawn. That was very good. I enjoyed listening to that and would look forward to sharing that again as we go forward. So now we have Dr. Crayton coming on. And Dr. Crayton, for those that don't know, she is an MS neurologist. She has been in the area for quite some time. She is the medical director of the MS Center of Greater Washington. And when I say Greater Washington, we're talking about Washington, D.C., not the state of Washington. So let's welcome up Dr. Crayton. I'm going to be invisible again. Well, not invisible, but you won't be able to see me. All right. And I will come back on during the Q&A. So I'll let Dr. Crayton handle this however she feels best to handle this. Okay, Dr. Crayton, take it away.
Thank you, Stuart. And thanks for having me. Thanks for the invitation. It is a pleasure to be here. I'm not used to holding a mic. I'm used to like kind of using my hands and flinging around, but I'll do my best not to drop it. It is a pleasure to be here, and thank you all for coming out tonight. I always say it's kind of hard to come out on a school night, and then the rain kind of didn't help. So it's really, really nice to see you. And those of you online, I can't see you, but thanks for joining. You know, what Stuart does is really a wonderful, wonderful thing. I've been following Stu's News and Views, when it was called that, for quite some time. And he really provides such a wealth of information from different perspectives. It's really, I think, helpful to those of us who don't have MS. We glean a lot of information and a lot of insight from Stuart. And to make these things happen, I think is really, really great. So when Stuart asked me to do this, I had no idea who my co-speakers were going to be. And it was just at the very last minute when I saw a final agenda that I saw who was going to be speaking. And two of my very favorite women in the world were here tonight. So it just was icing on the cake for me. So I've been tasked with kind of discussing several elements of MS. What I'd like to do is kind of talk about MS, kind of talk about MS 101, talk about some elements that I think are really important about MS. And then maybe at the end, maybe kind of have a dialogue with Kamilah and Dawn to kind of share perspectives, to have an interaction between kind of healthcare provider and somebody with MS. So I was tasked with talking about some of the newer products to the market, and tasked with teaching you about what's important to self-care, taking care of yourself what translates into better MS, self-care equaling better MS. Let's just start with a little MS 101. And for anybody who's heard me speak before, I do like to educate. I see people sometimes who've had MS for a really long time who still are not quite sure about correct details. But I see people sometimes who've had MS for a really long time and are still under misconceptions, or they don't really know exactly what their MS entails, or frankly, how to be a really good MS patient. And there is a skill to that. There is something that you need to understand about being a good MS patient. You've heard a little bit from Dawn and Kamilah, but I'm going to just add to that as well. So, you know, I saw that my last patient today was a young man who came to me for confirmation of his diagnosis. He was told that he might have MS. So he came to me to confirm, and I told him, yes, you do have MS. And I don't do that very often. Most people come to me with a diagnosis of MS. And I was a little bit taken aback because I had to really kind of put myself in that place of that vulnerability, and where there's a little bit of hope that maybe I don't have MS. And I, in essence, took that away from him and said, yes, you do have MS. I take it for granted. I live and breathe and work with MS all day, every day for the past 27 years. And I think I can't imagine not being a part of the MS community, but I have to sometimes remind myself that it is very, very scary. It's a frightening thing to be told. And we don't do a very good job of it as healthcare providers anyway. We give you these 2 letters, changes your life, and sometimes we don't do that very gingerly, very respectfully. And we need to remember that this is life-changing. It doesn't have to be bad life-changing. It's just life-changing. So I say to people when I confirm their diagnosis, you know, welcome to the club. There are a lot of things that that people would rather have than MS, but I don't mean to be flip when I say to newbies, but I do say there's no better time to have MS than now. There is so much going on with MS. There are so many treatment options for MS, and we really are so close to being able to really, really personalize care for your individual MS. And that's what's really important, because everybody is so different. You've always been called snowflakes. You know you have the snowflake. I hate the word disease. This is not leprosy, so I like the word condition. But everybody is so incredibly different. We cannot treat MS generally the same. My personal passion is ethnic MS. I treat people ethnically. I treat white MS very different than non-white MS. And I think we need to really look at an individual person who is sitting in front of us to confirm that diagnosis, to talk about their individual MS, to talk about quality of life, to talk about expectations, to talk about whatever disease-modifying therapy is appropriate for that one patient in that moment. In addition to how are we going to get you functioning the best and being the most able to forget that you have MS, because that to me is the treatment goal, for you to forget that you have MS. If you can kind of put it in the back seat, kind of forget about it, then I've won. And I think that that's possible, sometimes not always, but to at least have brief periods of time when you can actually forget about the fact that you have MS. And that's about quality of life. That's about symptom management. And symptom management, I think, is something that we don't universally do very well, but that's really what people with MS care about. You don't necessarily care about whether or not you have a new spot on your MRI. You want to know that you can sit through your child's sporting event without having to pee every 5 minutes, or that you're going to have the energy, the bandwidth to be able to get yourself ready and out the door and not have such debilitating fatigue that you're done for the day at 10 a.m. That you can actually get up, walk, move, and not feel anxious because you're so unstable. These, you know, it's living with MS that we need to do a better job of helping you with. We've done a really good job with developing products to be able to treat MS very successfully. We're still a little bit behind on the personalized medicine part, which product is the best product for you, because not all products are the same for everybody. And just because we have 20-some products for MS, doesn't mean that they're all applicable or that they're all appropriate for treatment. My personal bias is that several of the products that we have on the market are kind of passé. They're a little old school. I don't talk to people in my practice about, things that have been around a long time. I like to start with a little bit more effective medicines and medicines that truly don't affect your quality of life more than MS. So it's nice that we have oral options. We have pills. Pills don't make people feel sick. Pills make you feel like a normal person. When all we had were self-injected products, people would say, yeah, you're telling me that I'm a well person, but I take a shot. Well, people don't give themselves shots. And number two, sometimes I feel really, really lousy with that shot. So you're telling me that I should be a well person. Well, I'm not. And I totally, totally understood that. And I bow down to all of you who did that for a long time. But there's no reason to be hazed anymore. We have products now that really can make your life much more normalized, and certainly where we don't have to make you feel worse than your MS with the treatment options we have. So we have oral therapies, we have infused therapies. Some of the newer therapies we have a couple of things that entered the market actually just as the pandemic was coming around. And that made it a little bit difficult because here we are 4 years later, and many docs and many people with MS have never heard of some of the newer entrants to the market. So it is really important for you to be educated and to know what your options are and to know if you're happy with your product, with the product you're on or not, because we do have newer products. Now, just because things are new doesn't always mean they're latest, they're better maybe than what you're on. But the goal of therapy is stability. I know that doesn't make most people happy. We're not at the place yet where we can erase your MRI. And I know that that's what people really are interested in hearing about and are truly waiting for. But I just want to remind you that the expectation and the ultimate goal is stability in terms of MS. To have things not change, to have MRIs that don't change, to have you not change, to have exams that don't change. So when people come to see me and I say, so what's new, what's going on? And they say, everything's the same. And I get really excited and I'm woohooing, and they look at me like I'm kind of crazy and they say, but that's not what I want. And I acknowledge that and I totally understand that. But you have to remember that is our goal. That is our treatment goal, stability. Because by definition, MS is an ongoing progressive neurological condition for which we do not have a cure. So stability is a really, really, really good thing. We already undone the definition of MS. With some symptom management, we can even do better. So it is up to you to understand whether your MS is well controlled, whether you are in fact stable, and only you know these things. And that's what you forget. You forget that you are really in the driver's seat. It is your responsibility to bring your agenda to the appointment with your healthcare team. It's your responsibility to know your MS better than anybody else does. Don't ever let a doc tell you that they know your MS better than you do. That's impossible. So it's up to you to know, is your MS quiet? Maybe not quiet, you might have symptoms, but is it pretty stable? No relapses? If you're still having relapses, frank relapses, not fluctuations in symptoms, but if you're really having relapses, you need a different medicine. The name of the game nowadays should really be that you don't even remember what a relapse is. We have medicines that can do that. So if you're still having relapses, that's a problem. If you're on a medicine that makes you feel worse than your MS, that's a problem. If you get very anxious and nervous and scared about the medicine that you're on, that's a problem. Because there are too many options out there. You should be able to feel comfortable, to feel safe, and to feel like you're on something that is the most effective product for your particular MS. Sometimes people say to me, it's really difficult for me to know when I'm having a relapse. I'm not quite sure exactly what a relapse is. Sometimes it is kind of hard. But I also hear people sometimes talk to me about relapse after relapse after relapse, and I have them break that down, and I say, oh, that's just fluctuation in symptoms. So most people have a constellation of things that's always their reminder. Those little things are, just in case you forgot you had MS, Those little things that just are there to remind you that you have MS. Fatigue, maybe a little spasticity, crazy bladder, fatigue, things like that. And sometimes those things fluctuate a lot. Sometimes they really, really fluctuate. We don't like that. We can certainly make that sine wave a little more shallow, tightening up symptom management. Those things are not relapses. Those things are your barometer. And you, if you know your body and you listen to your body, well, and you're past the denial stage, because denial doesn't really help you out. You kind of put those things aside, you don't really pay attention to those things. But when you have those barometer things, you know that they get worse when you're tired, when you're stressed, maybe when you're hot. And that's to be expected. Most people with MS say, I'm different in the morning than I am at the end of the day, and I'm different from day to day. So I know with my patients, most of my patients see me about the same time. We have, the 8 o'clock people, the 10 o'clock people, the 11 o'clockers, the afternoon people. And when people that are morning people switch it up and throw me off by coming at 3 because my schedule was wackadoodle, I have to be really mindful of that because they're probably going to have a different exam. So it's really important for you to know your MS well enough to know that, because then it also puts you in the driver's seat of when you want to do things that are really important to you. Symptom management is really important as well. It's important for you to know what kind of symptoms you have, if they bother you, when they bother you, and if you want them treated. And if so, when you want them treated. Don't let us tell you. That's really not our job, because we'll probably screw it up. Only you know what your symptoms are, because you live in this body all the time. You know your MS. You know if you have a symptom that bothers you. And I use this one example, and it was an example when I was back at Georgetown a long, long time ago, and it taught me a huge lesson. I had a patient who was in a wheelchair, and she had a little bit of upper extremity strength. Her legs, she had no strength. She was in a wheelchair, and she was spastic. Her legs were very stiff, very tight. And I thought, gosh, there's not a lot I can do for this woman, so I'm gonna treat her stiffness, her spasticity, and I was gung-ho. So I was all about it, put her on some baclofen, told her how to use it. She and her husband came back the next time, and they were a little bit miffed with me, and they said, you've made her more disabled. And I thought, she's pretty disabled. How could I have made her more disabled? And before I was so gung-ho about treating her spasticity without really asking her, she had very stiff legs. Well, when her husband transferred her, he was able to stand her up. She was able to support herself with her stiff legs, and he could turn her and put her in the next seat. I took that away because I made her legs noodly and jello, and I made her dead weight in his arms. I made her more disabled. And one thing that she could actually help her husband with, she couldn't do anymore. And it was a really important lesson that I never, ever forgot, to ask people if they have symptoms that they want me to actually address, or if they're okay with those symptoms. And only you know that, and you must bring that to the attention of your healthcare team. So I talk a lot about sleep. My patients know that the 2 things that are most important to me, no, it's not sex. It is sleep and pooping. These 2 things, any nurse that joins my staff knows that these are the 2 things I better hear at least 5 minutes of a discussion on both of those things, because if those 2 things are off, everything is bad. Sometimes you don't really talk about those things with your doc, your healthcare team, and those things are really, really important to quality of life. And if you're not sleeping, life is bad. That means you have peanut butter brain. You want to blame MS, but your computer doesn't work so well if it's not ever turned off and rebooted. I always think about sleep as, the analogy that I use is when you're walking around the streets of Manhattan, when you're in New York City, you walk around at night and you see, can you leave my salad there? Leave my salad? Oh, this was gone. When you're walking around the streets of New York, you see trash all over the place, all over the sidewalks. You wake up in the morning and the trash is gone. It's a miracle. It's just a miracle how that happens. But your brain is the exact same way. So the garbage collectors come out and clean up at night. And this is not just for MS, especially for MS, but it's really for all of us. Many of us think that sleep is something that happens when everything else is done. And sleep is kind of whatever's left over in those hours in a 24-hour period. But if you don't give the garbage collectors enough time to come out and do their job, then you're starting your day with glitchy pathways. You have trash in your streets, but you expect to be processing quickly. You expect perfect pathways. It's not going to happen. So one thing that I say to people who are diagnosed with MS is you have to really protect your sleep. And a nurse who used to work for me who had MS said, I always protect my sleep. Sleep is really, really important. I'm not going to talk about poop a lot because people are eating dinner, but it's also very important. So symptom management is really, really important to your quality of life. Nutrition is really important. It's about having a healthy body. People ask me about a diet that is the best diet for MS. There's no diet that is the best diet for MS. You can eat 10 pounds of kale a day if you want. You can eat fermented products. You can drink kombucha. You can have organ meats. You can, whatever. But all of those things tend to be a little complicated and a little stress-inducing, frankly. People get a little stressed out if they have, only 5 pounds of kale a day and not, 6 pounds. But if you can treat your body like a temple, it pays you back in spades. So I say to people, if you can eat as much color and crunch as you possibly can, try to stay away from white taupe food, gray food. If you can drink 2 liters of water a day, 30 grams of fiber a day, if you can move your body for 20 to 30 minutes a day. It's so simple. If everybody in this room did that, including me, we'd be in great shape. People say, no. Just tell me the diet I need to follow. So nutrition is important. Sleep is really, really important. It's maintaining a healthy body, and it's also taking care of those other medical issues that you might have. Diabetes, high blood pressure, high cholesterol, smoking is a no-no. Anything that you're doing to your body that is not a healthy thing impacts your MS. And people that are healthy have a lot more wiggle room. They can take bigger hits and be less affected by them. They can have problems, relapses, and they recover. They bounce back quicker, and they have more recovery. So it really does pay off. And you have to be just really, really mindful of that in general. When you have a chronic health condition, it's your responsibility to treat your body like a temple, because it will pay you back. Let's segue over and talk about MS medicines a little bit. I kind of started earlier on talking about medicines and newer medicines that came to the market. And we started off with products. I like to start with Once Upon a Time. And the Once Upon a Time was that we had nothing for MS. It was diagnose and adios. We had steroids to help people feel better when they had a relapse, but there was nothing that we could do to really stave off change with MS. That changed in the 90s when we started to have self-injected products. And those products, those products made a little bit of effect. They certainly, it was the first time we could actually do something to try to stave off change with MS. We had those products for quite some time. 90s, early 2000s, we had Betaseron 1993, May of 1996, Copaxone came out, September of 96, Avonex came out, March of 2001, Rebif came out, and then things were quiet for a while until Tysabri came out. Tysabri came out in November of 2004, came off the market in February of 2005. It was a Monday morning. It was blue skies. It was the most gorgeous day you could ever imagine. And it was a day that things changed for the MS community because it instilled doubt. Tysabri left the market, and I remember going in March of 2006 to the FDA advisory panel hearing. Was anybody in this room at that meeting? So I had been involved in the Tysabri clinical trials, and when it was taken off the market, people were pretty devastated. And there was an advisory panel meeting for the FDA where they gave people 3 minutes to speak about why they felt the Tysabri should return to the market. It was pretty amazing. It was pretty emotional. And it was the first time we ever had a product that actually changed how people felt and really actually changed people's perception of what MS could really be. Long story short, the product came back out in 2006, and then things were quiet for a while. So July of 2006, Tysabri came back to the market, and then we had nothing again until 2010. What happened in 2010? Anybody know what came to market in 2010? The first pill? No. Yes, it was Gilenya. Gilenya was the first oral to the market, and it finally gave people, it was higher efficacy than the shots, but it also gave people a chance to finally be off injectable products. And I thought everybody would want that. Every patient I saw, I was like, oh my gosh, I'm so happy to tell you I finally have a pill. And I was amazed at how many people said, what? I'm not gonna come off my shot. And I said, what? What are you talking about? Are you nuts? I'm going to write down in this note, this person has very poor insight and very poor judgment. And they said, well, it's new, it's different, and I'm doing okay. And I said, what do you mean you're doing okay? You have a pit in your stomach on the day you have to give yourself a shot. You feel like garbage. You have to recover after you do your shot. What's okay about that? And it really was very hard for me sometimes to forcibly take people off of their shot and give them permission to do something that wasn't as traumatic. I still, in my practice, I have a handful or so of patients that are martyrs, and I will say they are martyrs because they feel like if they're not suffering a little bit, they're not doing enough to fight their MS. And every time I see them, I talk about it, and they put me in my place, and I say, okay. So, but that was a game changer for a lot of people. And then things went along for quite some time, well, a couple years. We had Tecfidera, we had Aubagio enter the marketplace, we had Lemtrada enter the marketplace as an IV therapy in 2014. We had Ocrevus enter the marketplace in 2017. And granted, all of these are very different mechanisms of action, which is really, really cool. Because when the injectable products were on the market, they all kind of did the same thing. All the interferons did the same thing. Copaxone had a different mechanism of action, but the interferons were really all kind of the same. We would switch you from product to product to product, but they all kind of did the same thing. And so it was really, really cool to have different mechanisms of action. And for me, I felt like, wow, we can really, really personalize care for an individual person. We can really assess what kind of MS they have, and really, really tailor a product that's going to fit the best with who they are, what their lifestyle choices are, what they expect from a therapy, what their demands of life are. And so that was really, really cool. And then things were quiet for a while. We had entrance of, so in 2019, we had Mavenclad come to market, which was another oral therapy, finite dosing therapy. We had Zeposia come to market as well, which was very similar to Gilenya. But it happened in 2019, and then pandemic hit when they were marketing, so nobody ever really got a chance to hear about those products. So 4 years later here, a lot of people have never really heard of those products. Briumvi is another product that entered the marketplace that people don't always hear about unless they are hearing about it from their provider, another B-cell depletion therapy. So we have products that tuck cells away in timeout. We have a product that is a security guard at the gate, doesn't let cells into the nervous system. We have products that are reboot mechanism, wipe out T and B cells and allow a different population to return. We have products that deplete B cells. B cells are the bullies. They get the T cells revved up to go in the nervous system and misbehave. So we have B-cell depletion therapy. I forgot Kesimpta's in there. We have 3 B-cell depletion therapy products. We have Ocrevus, Briumvi, and Kesimpta. So we have products now that allow people that don't have access to infusion centers, don't have access maybe to a big MS center, can actually be on highly effective medicine and be able to do it at home, be able to do it without having access to infusible therapies. So we have a lot of options. We also have now a biosimilar product that is going to be part of the marketplace. And I've been involved with this product, this company, and learning a lot about biosimilars. So I'm going to spend a couple of minutes talking about what that is. As you know, we have a lot of our medicines that have gone generic. Our oral therapies have gone generic. Aubagio is generic as teriflunomide. Tecfidera is generic as dimethyl fumarate. We have only a couple of orals. We have Vumerity is an oral brand, 2 pills twice a day. Zeposia is a brand product. Gilenya is fingolimod, that is now generic as well. We don't have generic infusions, but we do have a biosimilar. Has anybody here heard of Tyruko? Ever heard that term, that word, that name? So Tyruko is a biosimilar form of natalizumab. Natalizumab is the name of Tysabri. And they are, the company that makes that product is trying to introduce the concept of biosimilars to neurologists who see MS and into the MS community. And we're not really used to that concept. Biosimilar products are not generic products. What I learned in working through this is that there's actually some wiggle room with brand name products. I didn't realize how much wiggle room there was with brand name products. Brand name products are allowed to have a little bit of difference in between batches. Not every batch is exactly the same for a brand product. I did not know that. So there is an acceptable wiggle room between brand product batches. And biosimilar products are as similar to the reference product as the reference is to itself. So they have a little bit different process in coming to market, whereas products that you know well for MS, when they come to market, they start off with smaller trials that deal with drug concentrations in the bloodstream. Then we see, is there an effect on the MRI? And then we have larger trials to see if there's efficacy that we want from these medicines. Biosimilar products, the illustration that's in my head is kind of an upside down reverse of what I just said to you. They don't do these huge clinical trials to see if it's effective because they make a product that is, and with these larger molecules, these biological large molecules, they're making a product that is identical. So the efficacy doesn't have to be proven because it's the same molecule. What they're looking at is, are they able to achieve the same blood levels? Are they able to be really superimposed? So the trials that are done are against the brand that you know, the biosimilar, and then there's a crossover to see if there's any difference when people switch over. And there's not. The only time that we ever have dealt with biosimilars in the MS space is with rituximab, which is a generic product that is used, it's a B-cell depletion medicine. It's really interesting because rituximab has always been used off-label when it's been used for MS. It is not approved for MS. It's been used off-label. And whenever we really wanted to use it, insurance companies wouldn't allow it because they said it's an off-label use of that product. But lo and behold, now the VA and Kaiser prefer to use rituximab because it's a little bit less expensive than Ocrevus or Briumvi. So it's just kind of interesting because it was never really approved for use with MS, although it is used quite a lot for MS. But rituximab is the only product in the MS world that we've heard the word biosimilar used for. I have been called, the few patients I have on rituximab, I've been asked by an insurance company to allow for a different product, a biosimilar product, to be used instead of this particular brand of rituximab, which is a generic. Rituximab is not a branded product. So it sounds a little complicated, but it really isn't as complicated as it sounds. But over time, you might be hearing, if you're on natalizumab, if you're on Tysabri, you may be hearing about Tyruko, for instance, which is a biosimilar product, and that may come up as a potential switch along the way. And they have a JC virus assay and all of that. So as far as the patient experience is concerned, it won't skip a beat. It'll be the same patient experience and the same experience for the HCPs, for your healthcare team. So we have these products, and you're kind of at a little bit of a disadvantage because not all healthcare providers know about some of the newer products. So it does behoove you to educate yourself so you can kind of be in the know and maybe have discussions about those products and whether those products are maybe more appropriate for you than what you're on. But first of all, it's important for you to know whether you're happy with the product that you're on, whether it's keeping your MS stabilized, whether you're less lumpy bumpy, to make sure that you don't have side effects that come up because of the product that you're on. We don't want that. We have enough symptom issues with MS. We don't need them from the product that you're taking. And that your symptom management is tightened up, because that affects your quality of life. That's what really determines your level of function and how well you're going to function and live your day-to-day life with MS, and whether you're going to kick MS's ass or not. So I'm trying to think of all the things Stuart said that I had to make sure I covered before I go rogue. Let's see, I think those are mostly the things that I wanted to make sure that I covered. The other thing, what I'd like to kind of do is spend some time. I'm going to ask Dawn and Kamilah to both come up here, because I think this is a great opportunity with two women that I respect, I adore, to really have kind of a little bit more of a conversation about the healthcare provider and people who have MS, because I have some questions. I'd actually like to interview them. I don't get to do that in a fun situation. So come up here. One thing that I think is really important is I know what your product histories are. But I think it's something that healthcare providers don't always take into consideration. We don't always think about the impact of hearing about these medicines that come with risk. The word risk is really thrown around a lot. And when I even speak to colleagues, they say to me, which I think is kind of BS, but they say to me, patients are risk averse. I hear that a lot. And I say, I don't think patients are really risk averse. I think that we don't do a good enough job of discussing risks and benefits. We think we are, but we're really not. Because proper risk-benefit conversation is to talk about the risk of a treatment, a procedure, a medicine, and the risk of not doing it. So I believe our job is to look at these individual MS and say, this is where I see your MS headed. And so given that, this is what your future looks like. That has to be part of the mix. Given that, given the risk layout for your MS, this is the risk of these various medicines, and you have something to really weigh. So both of you have been on medicines that there was a risk-benefit conversation. And when you hear this stuff, it's kind of tossed out there, very kind of laissez-faire from the healthcare provider, because it's not us taking it. So I'm going to ask you first, Kamilah, about how you dissected that, how you digested it, and how you dealt with making the decision to pursue a medicine that came with risk.
I preface this answer with me and Dr. Crayton have known each other for a number of years. So when we had this conversation with regards to risk averse, I was on the other side of 20 and didn't really look at it as a risk versus reward kind of conversation. I was more looking at a balance of what is my quality of life going to look like and what is my longevity of life going to look like, and trying to figure out how to balance that the best. How much quality of life was I going to get? And then how long could I have that quality of life? You know, I wanted to dance, I wanted to go to salsa club, I wanted to go to London. And was this new medication that she was talking about going to give me that kind of good balance? So sometimes I think with doctors, it's not necessarily a risk-averse conversation. Sometimes I think they forget to talk to us about quality of life versus longevity of life. I go to a lot of doctors and they're always talking about, well, you just want to extend your life. We want to extend your life. It's like, I will tell you in a heartbeat, I will take 3 days on a beach before I will take 30 days in anybody's hospital bed. And I think sometimes that's not always the doctor's goal. And that's not a bad thing. It just needs to be an appropriate balance. Don?
Okay, can you repeat the question once more?
So being presented with medicine options that come with risk, easy for the doc to say, oh, it's not a big deal. You know, these are the risks and I can monitor for that. But as somebody receiving that, hearing medicines that come with certain risks, kind of how do you digest that? How do you decide to move forward with something that might be risky?
The first thing that comes to mind is trust. I trusted you. I believed in the treatment, in the process, and I believed that what you were presenting would be something that was beneficial. I never thought about quality of life like you just spoke about. I never thought about risks. I thought about, do I trust her? And I thought about fear. I'm afraid, and so something has to happen. As you know, I was a bit reluctant and resistant to receiving one of the more recent therapies because there was a lot involved. I wasn't thinking about longevity. I was just thinking about, like you had mentioned, being able to be at a soccer game and not having to worry about using the restroom of myself or even walking across the field. Those were things that I was thinking about. But I suppose that is part of quality of life for sure, but I didn't process it in that way. The only thing that I was processing were the two words that I just mentioned, was trust and fear. And they went tandem at that time. And I knew that I no longer wanted to be in this fear of treatment burden, because I felt as if the monthly infusions were a burden. It worked until it didn't work. And I felt that this is causing some sort of heaviness, or for lack of a better word, it was a burden. And I never would have gone through that last treatment if I did not believe in you and believed in the education that you provided. It's a blur at this point, but you did a phenomenal job. And I think that doctors, healthcare providers must provide the literature. I think you and your team went through every bit of this process ad nauseum, and you answered every question. But it's also on the patient to do the research. And I remember doing that research with my family. Did you do the same when you?
Absolutely. You've got two of the most interesting people up here, because I'm a researcher, I'm an analyst, and I run numbers. So I am very good at trying to figure out exactly what are the percentage points from this perspective? What are the percentage points on this perspective? How can I make the best decision with the information that I'm presented with at that moment? I do have to give myself grace, and I think that we all, as individuals on our MS journey, you are making the best decision that you can in the moment that you have with the information you have at that time. So regardless of what decision you made then, if you need to change it up, don't be afraid to do that. But definitely do your research, analyze what's going to be the best for you. I think that in our own way, we both talked about longevity and work-life balance, and being able to walk across that soccer field and sit in that heat. I am a summer baby. When I found out that I couldn't lay out in the sun like I used to anymore, it was devastating, right? It's summer babies, right? What? But I learned to adjust and to cope and get the cooling jackets and to take the hot showers and to stay in the shade a little bit better. So when you talk about these medications, and we trust the information that you're giving us, and we trust that you are having our best intentions and effort up front. So I think that's how we both approach this.
And just the last thing I'll say, you had just mentioned the what if, and I thought about it in this last treatment, and I thought, well, what if this happens, and what if that happens, and all of the anxieties that you go through when you are switching from one therapy to another. And although the previous therapy wasn't working, I knew that I had to take some sort of calculated risk, and I knew it was important for you to see me follow through and to see me enjoy life, because I'm still young, and I was young 5 years ago too. It's
you guys are both babies to me, so.
And of course, cog fog, and I forgot my thought, but.
Because I interrupted you.
No, it was before that, but it's just, I knew that I was making the right decision because of like I said, the communication that we had, and that I didn't really have another option. I felt I had made that, not that you told me that or anyone else. I felt that. This is what I was going to say. Instead of going down the road of, well, what if, in the negative way, well, what if it does work? Think of that. And that's what happened. And it did. I was using a cane, a walker, a wheelchair. My son will tell you, I was leaning on his shoulders, asking him to help me. I was not walking. I think you even saw me. And after this treatment, I miraculously woke up probably 9 or 10 months later, walked down the stairs and totally forgot that I needed to utilize an assistive device. So I trusted you, and that was important.
Let's move on. So I think of you both, I've known you both of you for such a long time that I do think of you as, when I saw your husband, I was like, Kamilah's my baby. How can she have children? Like, that just can't be. She's a kid. But I've seen you guys go through, both of you, through these stages of life, and being young and independent and frivolous, and then being responsible grown-ups. And I'm so proud of both of you for the women that you are, but both of you have navigated being mothers. Being mothers with this diagnosis, navigating that whole issue, which is a hard thing for somebody who doesn't have MS. And then when your children are of a certain age, deciding that you're going to share that with them. This is something that comes up actually quite a bit with women in my practice. Is the first big hurdle is deciding to make babies, have babies, going through all of that, and then, oh my gosh, like maybe I'll never tell them, I have some people that say I will never tell them, and I think that's a huge burden. But I'm just curious to know when that happened, how you thought about that, what was your internal dialogue about sharing that with your family, your kids?
Well, in my case in particular, when we decided to have children, my family and my husband made me one big promise. He said, don't worry about it. They will get the best parts of both of us. So you don't have to worry about either one of them. That was my concern. It's like, I don't want them to eventually develop multiple sclerosis. But I've been promised that that's not going to happen. So they're both here and they're fantastic.
Less than 3% chance.
Yes, they are fantastic kids. Deciding to share this with them ended up not being an issue in that sense, because when they came along, I was already running the foundation. And so it's always been a part of their lives, being advocates for individuals with disabilities. They have always been at the presentations, they've been at the speeches, they've been at the rallies. They've been doing yoga with me from day one. So it has never really been that type of conversation of multiple sclerosis is something to be afraid of, or it's a disability. Do we talk about the stigma that people can face, particularly as women of color, having a disability in this world in general? Yes. Do we talk about how to address that? Absolutely. But sharing the conversation and making them aware of what it is, how it affects mommy, how you're going to help me with my IVs sometimes when I have to go on a round of steroids just to get myself back to baseline. It's never been that type of burdensome conversation. We've been open and honest. And I think that for us, that has been the best way to approach it. I do understand other families. I know that when I was first diagnosed, our family went through that conversation. It's like, you know what? You don't have to tell anybody. Nobody would even notice. You're doing so well. And you're already a woman of color in America. Do you really want to be a triple threat and deal with that additional stigma attachment? But I found that having these conversations gives me more strength. I think that's the one thing MS gave me instead of taking from me.
Absolutely. Yes. That is, I agree 110%. I did not feel any sort of reticence or even pushback. No one advised me in a way stating, don't tell your son, don't talk about this, don't share this with the family. MS is a part of me. It is, as you've said, Dr. Crayton, it's an unwanted spouse. And actually, I find that having an open, honest dialogue with my son has been so helpful, because he can digest when I'm really tired and understand, my outbursts. And I scream sometimes, or I'll yell and I'll say, I'm so tired.
So do I, and I don't have MS, so come on.
Is it the dishes?
Right. But then I go back and I say, you know what? I apologize. I said it's not you. It's the MS, and I'm really tired. And I think having that open and honest discussion with him, he understands that, there are times where I'm irritable, and there are times where I just can't be everything. I can't do it all, and I say that. And I always hope when we do have those conversations that I'm teaching him not only resilience, but just, following through. If I say I'm going to do something, I do it. And I do the best that I can. But I think that in our small family, I'm divorced, we have made it comfortable for us, because he knows when to let me sleep. He'll say, okay, Mom, I know you're tired. Or I even overheard him, sorry, Dustin. He was talking to a friend of his, and he was saying, well, my mom has MS, and it's an illness that affects the central nervous system. And I was so proud of him. And he was just giving the whole breakdown of it. And I thought, he really understands. And we actually, just 2 days ago, we had a conversation about MS. And he said, well, Mom, did you have MS before me or after me? And I said, well, I had it after you. And I said, actually, you protected me. And I explained, medically how that happens and what happens. And he said, well, what happened afterwards? I said, well, I had a bit of a flare, but it's not because of you. It's just because of how the body works and hormones and things like that. And then he asked me a question, which I thought he understood. And he said, well, is it contagious? So I'm sure you've had this conversation before, or those types of thoughts have come up. He thought, well, I get it. And so that's something that we will talk about with as a family, just to reassure him. But to sum it all up, I think being open and honest works for my small family.
And when he actually calls you from college and says that his arm has fallen, or that it's numb and tingly, it's probably because he fell asleep on his arm. You will go to the dark place and you will go 0 to 60, but it's probably just because he fell asleep on his arm studying. So keep that in mind. I will remind you of that. Yeah, you remind your mom of that too. Nice. Another thing that I think was on my task list was to talk about resources. And I think this is something that, again, neurologists, the MS community is not always great about resources. When somebody is diagnosed with cancer, there's usually a nurse there that's part of that community that draws you in, tells you about these support groups, puts you in touch with support, resources for various symptoms that you might have, how to navigate decisions. There just seems to be a lot of support in place. With MS, we give people these 2 letters and send you out the door. It's really pretty lousy because we've totally changed your life and don't have necessarily a map or a way to guide you through it. And I think that resources are really, really important, and to know that first of all, you're not the only person experiencing a particular issue, a thought, an emotion, and kind of where to go to help you navigate all of that. And I think that that's really, really important. How did you guys, because I don't think I did that really so well with either of you in the very beginning, how did you navigate that? What did you look for in terms of resources? What was your go-to? How did you get information? How did you get answers?
We're old, so I've never dialogue.
Spent a lot of time in the library initially. Like I said, researcher and analyst. I went down to NIH. I went down to Johns Hopkins. I went down to Library of Congress. That's the great thing about being here on the East Coast. I had access to a plethora of information. But even with all of that, there was very little with regards to multiple sclerosis, particularly in young people, and particularly in people of color. So I talked about it. I began reaching out at that time in the various political circles that I was in, just mentioning, it's like, I've just recently been diagnosed with multiple sclerosis and I need to take some time off. And they're like, oh, really? My cousin has that. Oh, no, my uncle has that. And from there, I did start a support group that then bloomed into the foundation. And that's the other thing with regards to communication. You have to talk about it. You don't know where you're going to find that support or who you're going to be able to touch and reach out to. And the more we gain and the more we connect and the more we communicate, that's how me and Dawn found each other. I was working with a friend of hers on Capitol Hill, and he said, a good friend of mine just got diagnosed with MS. Would you have breakfast with her? I was like, absolutely. And we've been back and forth ever since. So if there's a map, I don't think we've found it yet, but what we have found are a lot of good people and a lot of circles. And each one of those circles would touch each other in that sense. I still think DC is just this big. It's 3 degrees of separation. If I don't know that person, Dr. Crayton might know that person. If Dr. Crayton doesn't know that person, Dawn knows that person. If Dawn doesn't know that person, Monica Proctor, who's out here in the audience, will know that person. So we just have to be able to reach out to each other and say, hey, I might need a little help, or I might have a question.
Initially, I went to support groups. I think that you did provide information. It wasn't a lot, but at that time, 20 plus years ago, there wasn't a lot. And you did. So pat yourself on the back for that, Dr. Crayton, because you did do a great job. Like I have no complaints or zero critiques of what you didn't do, because I think you did everything that you knew to do. You provided the MS Society's information, and you said, go to support groups. Although
it was Kevin Daughtry, right?
Yes.
Kevin Daughtry, yes. You sent us to him.
Absolutely. As well as the online, that was just getting started. Online. Can you believe that online didn't exist, little one? And again, it was the dial-up, those AOL chat groups. And so I entered, that's where I found a lot of my strength, online. And going to the support groups at that time did not work for me, because I was still in my 20s, in DC. We were the youngest people there. I still wanted to wear heels. I wanted to wear makeup. I thought happy hour was the best thing since sliced bread. And how dare these people come in talking about their spasticity and their
vitamins.
Exactly.
And medication.
Exactly.
Where's the tequila?
Right. Right.
The depressing group have you sent me to?
And that's how I felt. So of course, I slipped into denial even more, because I'm like, that's not me. It will never be me. And you can't die from this. And of course, this is not Parkinson's. So I will be fine. I can go on a date and not shake. And, there's nothing against that. But that was my thinking. I did not do enough research at that time. But I think 5 years in, or even 3 years in, you went to the Library of Congress. I went another route. I went the route of massage, acupuncture, these, as they say, I know there's another word, but alternative therapies. And I'll never forget, you were at Georgetown. You had a short little haircut, and so cute, like a little Halle Berry haircut or something. And there was a medical student from Sweden or Switzerland. Nice looking guy, tall, blonde, just handsome young man. And you asked me if he could come in and talk to me, and he did. And we were talking about massage. And I said, I went for a massage, Dr. Crayton. And you said, this is something that they're doing over in Europe. And this gentleman, this medical student who was training or practicing or something, visiting Georgetown with you, talked about that and discussed it. So the resources that I found were in that holistic healthcare arena. And so that's what helped me get through those first few years. And I thought I was Superwoman, and I thought I can heal MS with eating right and changing my diet. And we can go on and on about how I have changed with, eating and things like that. And that led down another whole path. We can talk about that later. But the holistic route was where I found the resources, and of course, online. That's where my comfort was, because I wasn't ready, like you, to speak out and be seen. I was still in that, I'm not going to tell everyone because I look like I'm drunk when I'm walking.
All about Kamila's tequila. I think that, in context, you're right. I think it is really important to be able to align yourself with other people that understand what MS is about and what it's like to wake up and feel MSy. And I think, people that are around you, your family, your friends who really love you, unless they have MS, they really don't understand what waking up and feeling MSy really means. And I think that that's really important, to have somebody that understands that The issue with support groups sometimes, though, is not having anything in common but MS. Oh, Q&A, okay. And I think it's really important to be able to have somebody that you can kind of share, who you can identify with. You know, it doesn't make any sense for a 20-year-old to go to a support group where they're all empty nesters. You're trying to navigate as a 20-year-old, when I go on a date, do I disclose? Do I tell them first date, second date? And people are talking about the freedoms they have when their kids have left for college. So you need to have more in common than just MS. And I think that that's really important to kind of seek out as well. So it's time for some questions and answering.
Hi, yes, I do have a question, Dr. Crayton. Can you name one thing that you do different for your patients? You mentioned that you do something different, of course, for every patient, but that you do different for your patients of color that you do for other patients. Just one or two things that you do different.
That's a really good question. Nobody's ever asked me that question. So the question is, what do I do differently when I say that I treat people ethnically? I look at somebody's individual disease, their MS condition, and we know that MS is a lot more aggressive in people that are non-white. So when I know that I'm seeing somebody that is non-white, I think in a very different way. I think about how can I treat to the highest level of efficacy to really do the best job that I can at making sure that I can really keep them quiet. And I think about different medicines. I think about only high efficacy medicines. I don't think about lower efficacy medicines at all. I also have to take into account what somebody's lifestyle and job is. And I really try to educate, and I try to educate in a way that is really understandable. And I usually really try to connect somebody who looks just like them. So if I have a young black man, I try to connect him with another young black man. If I have a young Hispanic woman, I want to connect her with a young Hispanic woman in my practice, because I can talk the talk, but I can't walk the walk. And I think it's important for people, especially non-white, to know what the experience is, by definition, in a population that is less affected by MS. But we know when you're affected by MS, it hits you a little harder, and there are different things to navigate. So to be able to connect people is one thing that I take pride in, the fact that I do that.
This message is for Kamilah, or question is for Kamilah. Talk to me about dating.
Well, I can talk to you about dating prior to being happily married now for over 15 years. So, but when I was dating, to be perfectly honest, like I said, I really found that MS kind of gave me the freedom to cut out a lot of the nonsense. I typically would have, I was an equal opportunity dater. If you were funny, if you were smart, if you made me laugh, if I found you interesting, I would give you 3 dates. After about the 3rd date, I'd let you know I'm living with this chronic condition, which means I might not be able to hang out as late, which means I might have a whole lot of fatigue, which means this is something that I'm going to be living with for the rest of my life. It's not going anywhere. It is going to be progressive. And I would have an open and honest conversation with that individual and let them know that this is what my life looks like. And then I'd give them a chance. It's like, okay, now we can just be friends at this point, or we can see if it will go further than that. Some of them took the out, one of them did not. And that's how I approach dating.
Thank you for your responses. I have a couple of questions online that I need to ask. Okay, and the first one is for Dr. Crayton. What's the difference between white versus non-white MS, and the difference between male versus female MS?
So we know that men tend to have MS less frequently, but MS tends to be a little bit more aggressive. Men tend to have more involvement in their spinal cord, for instance. And we know that non-whites tend to have more spinal cord or brainstem involvement. The reason why we don't like those areas to be involved is that people then are very aware of their MS. Somebody can have quite a bit going on in their brain and not have any idea that they have MS. You have one spot in your spinal cord and you know it, because everything that starts up here has to go down through that glitchy area, and all information that you're getting from below has to go up through that glitchy area. I'm from LA, where we have 6-lane highways, and my analogy is always, if a car breaks down on a 6-lane highway, other cars can kind of go around it. If a car breaks down in a tunnel, we get big backup. Everybody knows about it. And that's how our nervous system is. So when I have a man, I think a little bit differently in terms of treating more aggressively. And when I have somebody who's not white, I treat more aggressively. There's another element with men as well. Men don't always come clean, and they usually have no idea what the hell's going on with them in terms of their medical history. So there's a little extra caveat that goes along with men having a chronic condition, because I always get a very different story when it's just the man at the appointment versus when a significant other, a woman, comes in who's sitting behind that man and giving me faces, nodding, giving me a whole line of communication when the man says everything is fine. So there are a couple of other things to be mindful of, but typically men and non-whites have more aggressive MS, and it needs to be controlled outright with very high efficacy medicine. Don't screw around.
Thank you for that answer. And the person just followed up with, what can you tell us about then Black men with MS? How much more worse off are they than a white man with MS?
Black men with MS tend to have more aggressive MS earlier on, and they have greater change earlier on. So when you waste time with lower efficacy medicine, you're going to be behind the 8 ball overnight. And we see this time and time again. You need to start off very, very aggressively, very, very early on, to ensure that disability is not something that is commonplace. Unfortunately, not everybody's on board with that way of thinking yet, but you see some big differences with people that are treated very aggressively out of the gate versus those that have more escalation therapy, where they started with lower efficacy medicine and finally got the good medicine when they were in a bad way. It doesn't work.
Okay, thank you. And another question that resembles or is part of this whole dialogue is that clinical trials in your area, how are they going with the Black community attending these clinical trials?
That's a really, really good question. Part of the reason why we don't really understand how to treat non-whites is because we don't really have much participation in our clinical trial programs. Most of the drugs, when they come to market, have clinical trials that are predominantly based outside of the US, Eastern Europe. Everybody's white. So when we try to do trials here, there are some issues in terms of recruitment. We have some cultural issues, that there's a lot of education over the past couple of years about diversity, education around cultural differences, that sometimes, for instance, Hispanic communities, it really takes a village, and they have a village. And to discuss any treatment option or to be in a clinical trial really involves the whole family kind of coming together to really understand that and to be on the same page about that. To get Blacks into clinical trials is a bit of a hurdle sometimes, because the United States doesn't have a very good a very good history with Blacks in clinical trials. There's a lot of distrust. And there's a lot that we have to kind of try to undo to be able to get more Black recruitment in clinical trials so that we can actually see differences, because we know that there are genetic differences in terms of manifestation of MS, differences in terms of how non-whites respond to medicine. And we need to see more representation in clinical trials because we don't have that now.
Thank you. So my question going forward with this for you, all of you, is number one, how do we get more people of color to be involved with clinical trials? And the reason why I bring this up often is, seriously, in the United States these days, the white man is the minority. When you bring up the topic of all the Hispanic Americans that are here, or the Hispanics that are in from other countries, and the Black man and the Indian and the Asian and the others. So the white person is truly the minority these days. And if future medications are going to depend on clinical trials, how do we get people of color to be part of these clinical trials to make sure that they are being treated well in the future?
Knowledge and accessibility are key. It really behooves people to know what's going on out there in terms of clinical trials. You know, I know for a lot of us, I do a lot of clinical research, and I usually kind of try to recruit within my own population first before I go outside of my population and try to advertise, for instance. And I think most centers do that. They usually recruit initially from their own population of patients. Sometimes the pharmaceutical companies actually will have on their sites, they will have the fact that they're doing a particular clinical trial. But it's difficult. It's difficult. We talk all the time about how to really properly recruit, whether to go into communities, into churches, into rec centers, into places that people trust, and to be able to talk about particular clinical research that's going on. One has to be creative, and that doesn't always happen. It is an uphill battle.
Okay. So my question for Kamilah, excuse me a minute. Your foundation is for people of color. How would you suggest getting more people to be there or to get involved with the clinical trials? Are you coming up with a way to speak with people about this, or is that something that you wish not to do?
No, it's something that we absolutely do. We are talking about medical mistrust in communities of color, particularly among men and African American women, and particularly among youth as well. As Dr. Crayton alluded to, medical mistrust in America is real. You know, Henrietta Lack was real. The Tuskegee trials were real. The most recent study, 2020, out of the University of Virginia, where it talked about how most medical students felt that African Americans did not feel pain the same because of the color of their skin, is real. So yes, the way that we can actually get people more involved, people of color more involved in clinical trials, is to have more of us at the table, have better and more consistent outreach, make sure that these trials are accessible. You're asking people to take off of work. You talk about the idea that African Americans and other people of color are taking over and we are no longer the minority. Statistically, I'm not sure if that's accurate, but I know that we are the minority when it comes to access to this because it is not accessible. I was blessed to be able to take time off from work to come in, because when you're part of a clinical trial, you have to come and get checked at least maybe once a month on the low end, once a week on the high end. Do you really think your supervisor is going to allow you to leave work? Most people don't have that kind of wealth built up. So between the wealth gap, the education gap, and then the ability to try and figure out how to properly advocate for this information and for this intersection, it is definitely an uphill battle. But we at the foundation are definitely working on it. We talk about it significantly, and we're bringing people to the table to figure out how to make these trials more accessible and how to build that trust that Dawn and Dr. Crayton talked about.
Great. Thank you very much. Very, very much. Thank you for that answer. Dawn, do you have anything to say about that? Because then we have a question in the audience.
Yes, just quickly, I think with the newly diagnosed population that I've been working with, I find that having a softer approach, if you would like for individuals to be interested in a clinical trial, individuals of color, I think coming to them being completely open and honest, and not from a standpoint of big pharma. I think that scares a lot of individuals. It scares people away from the entire conversation. And so when you speak the language and you meet them where they are, I think it draws them closer to wanting to gain more information and wanting to seek out what is this all about? How is this going to help me? How will this help future generations who are going through this process? So I would wholeheartedly say, have a softer approach and meet all of the individuals or the target audience where they are, and understand the language, understand that there is a specific vocabulary that you will probably need to utilize if you are wanting these individuals to find out more information and join in on the clinical trials.
Awesome. Thank you. Thank you for your response. Okay, we do have a question out in the audience. I want to take that, and then I have others that are from people online.
I noticed that during COVID, we started seeing a lot of ads on television about different therapies for MS. Have you seen that impact the questions that come to you from your patients about what their options are, and how should we look at those ads when we see them?
Wow, that's a great question. Nobody's ever asked that. I've never been asked that question. I personally do not like direct-to-consumer advertising for medicine. I don't think it's appropriate. I don't think that that there's a place for it. It drives business, though, that's for sure. And people see things on television, and the assumption is that's the best. It's on TV. I like the commercial. That's for me. And so products that have been on television have a huge market share uptake. And patients come in, and docs feel very pressured, frankly, when patients see these things on television and they say, I want to be on that. I've seen the commercial. And sometimes it's an uphill battle to say, I don't think that's actually an appropriate medication for you. People say, but that's what I want. That's what I want. They've been inundated with that messaging, either on television or social media. The flip side is, if something is not on a commercial, then it must not be that good, which is, of course, not true. So of our 20-something products that are on the market, right now there are only 2 commercials on television. That's Ocrevus and Kesimpta. Zeposia has a commercial on television, but it's for their other indication, ulcerative colitis. It's not for MS. It is a product that is approved for 2 different conditions. And when I first saw that, my head whipped around, and I said, oh my gosh, there's a Zeposia commercial. And then it was for ulcerative colitis, not for MS. So it definitely drives business, but I think it should be taken with a grain of salt. Just because something is advertised on television doesn't mean it's the best. And just because something is not advertised doesn't mean it is not a good product for you.
I'm hoping soon the clinical trials will look at older people, because we age out. And just like the older people will vote, older people will participate in clinical trials. But at some point, MS thinks that it's given us enough medications at 55. And we stop the trials at that age. And you're not going to get the participation you need from the African American community or the people of color community at the younger age. So you have to expand it, and we're living longer. So clinical trials need to expand also.
I totally agree. I totally agree with that sentiment. The trials used to be with an older population, or at least it went up to like 60, several of the trials. And the feeling is that as people age, 55 is kind of the standard now, right or wrong, because the feeling is that sometimes as people age, they have more other medical conditions that could get in the way, and frankly get in the way of a drug showing benefit. So that's not always the case. I have people, it's a very regional thing. There are parts of the United States where people are in their 20s that are in horrendous medical shape. We're in the DMV area. People are educated, they're healthier, they take care of themselves. It is very individual. It's not about a number. Unfortunately, it is like that. There are a couple of trials that are going up to the age of 60, but you're right, people age out. And who has more time to be able to participate in all the visits of a clinical trial than somebody who's over 55 or 60? But it is unfortunate. But in some cases, they're starting to creep up to 60. But I hear you.
People want to know if two different people asked this question, which I'll ask you, Dr. Crayton, is MS contagious?
No, MS is not contagious.
All right. And how, though, if not contagious, why are certain family members passing it down? Not necessarily passing it down, but people want to know, why is it that a mother and a child or a father and a child can have MS and maybe a few steps along the way as well?
It's a good question. I wish I had a great answer for it. We really don't know. We don't really know why we tend to see it sometimes. It's almost always a one-off. Somebody who's diagnosed with MS has never heard of MS. Nobody in their family has ever heard of MS. It's nowhere in their lineage, and it'll never be seen again. It's just a one-off. Because all I see is MS. I certainly have some families where there's parent to child, or several years back I had a young lady, and she was white, and she and her two sisters, all three girls, had MS. They had never even heard of MS in that family tree, and they went back pretty far. Nobody had ever heard of it. Nobody had ever experienced it. So there are these situations. We know that there's not a genetic direct transmission of MS, but we know that there's some genetic factor. We know that there's a 20% chance of a first-degree relative of somebody with MS having MS. We know that identical twins have a 50% chance, though. If one twin has MS, there's a 50% chance of an identical twin having MS. There's less than 3% chance of mother to child. So the bottom line is we really don't know. There's more about MS that we don't know. Fortunately, we don't have to know exactly why people get MS, what causes MS, to work on treating MS. But we don't have an answer to that question.
Okay, thank you for that. And yes, that was one of the questions as well about twins having MS. And I personally know more fraternal twins than identical twins having MS, oddly.
Interesting.
All right. Interesting indeed, yes. So going forward, what can you tell us about, please, about telehealth and where that's coming? The National MS Society was just part of an online event yesterday on the internet that was being live streamed from, I don't know if it was, I guess it was Congress, that they're helping, trying to make sure that telehealth continues. How widely is telehealth used in your area, and what do you have to say about it?
Well, despite the obvious technical gap with regards to individuals that do have access to the internet and access to high speed and access to assistive online technology devices, telehealth is here. It is here to stay. I think that once we finally bridge that particular technology gap, it is something that's going to be very useful with regards to communities and individuals that cannot get out to their doctors and to their healthcare professionals. From a medical perspective, in the interviews that I've had, most doctors do appreciate it as a way of trying to have an initial first visit and first conversation. It allows them to really see if I need to rush, jump, skip, get that person in here immediately, or if, okay, I can see right here, right now, maybe we'll give it some time, come back in 24 hours, take another check-in. There are some bumps here, but telehealth is here. It's here to stay.
I think telehealth is a very important option for people to have. I will say I've never done it. During pandemic, I saw patients in person. I never, ever embraced telehealth. For me, it's about laying hands on people. It's about really examining people so that I really understand what's going on with them. I need to understand how people feel emotionally. I didn't really give a damn during COVID. I hugged people, and sometimes it was the only time they were touched. So for me, it's about connection and building that trust and that relationship with people. So I'm a little old school, a little old fashioned. It's not for me personally, but I think it is really, really an important option for a lot of people who otherwise don't have great access.
Okay, thank you very much. Are there any other questions?
I just actually had a phone call last night about 11:30. A young lady from college had reached out to me, and she was diagnosed with MS. And she said that she was having these telehealth visits with her physician or her MS specialist. And I thought, okay, I'm supportive of telehealth for sure. And I agree with you, it's here to stay. However, I would feel quite uneasy and uncomfortable. I think Dr. Crayton's probably one of the only doctors that I would never, ever opt for telehealth, because I'm a firm believer in the laying of hands and her being able to see how am I reacting to, whatever tests that you give, the neurological. Right, exactly. And I think it just, it builds just that stronger relationship, and you are able to, I find in my visits with Dr. Crayton, I'm able to get more said, more things are understood. Telehealth is, for me, it has felt rushed, and I don't like that feeling with particular specialists, and I just wouldn't opt for that.
It's definitely not perfect yet. Right. It's definitely room for improvement, but the breadth that I've seen with regards to accessibility that is given to patients that do not have the ability to move, that do not have that mobility, that are far distances, and some that are just too weak or too sick to make it to the doctor, it has been a very helpful and useful tool. So I'm definitely looking forward to seeing how it progresses. The various technology conferences I've been to, it's definitely here to stay, and it's going to be in various VR versions very soon.
Thank you, Kamilah. I totally appreciate that. And I just want to add to that from my own opinion, all right? MS News is the leading patient advocacy organization providing programs in rural America and underserved communities. There is too much, and there's too many people in the extreme rural and remote rural areas of the United States that cannot see an MS expert. Okay, their community doctors are not giving them the right information about multiple sclerosis or other disease states. For me to know that these people can get on the phone with an MS expert and get the answers that they need, or at least be comforted to know that they might be being treated properly, I find extremely important. In addition to those that Kamilah mentioned about being too ill, what about those, though, that even are in urban America, metropolitan cities that have no transportation? They don't have family members living nearby. They don't have friends anymore because their friends abandoned them. They can't get on a bus because their bodies just don't allow them to get on a bus or a train. They can't rent a car. They have no other way to see or speak with a doctor than otherwise to be on telehealth. And so my 100% is behind everybody that wants telehealth for those reasons. Thank you. All right. We do not have any more questions online. We don't have any more questions there, but I want to let you know, Dr. Crayton, the idea that you had of bringing these two ladies up there to do this with you was spectacular.
Thank you, Stuart.
So much so that I'm going to write this into our new curriculum in certain areas where I know the doctors are really, really good with the people, and we can get those people up on the stage with the doctors or in the front of the room with the doctors. I'm going to try to do this at more than several of our upcoming programs, because I really, really dig it. All right. It was cool. And these
Never
two,
want to let you down, Stuart.
Kamilah and Dawn were excellent, and they were speaking with an excellent physician. And so I want to thank you all for doing this. It was fabulous.
Thank you,
Give me
Stuart.
a new twist on life. All right. Okay. So thank you. So again, I just want to thank our sponsors for tonight's program. We again had, I'm just going to list them off again. We had EMD Serono, Genentech, Novartis, Sandoz, and TG Therapeutics. And I want to thank them all for being here. And I'm going to say toodles to you all. Drive carefully and have a great night. Bye-bye.